Let's start immediately with the clinical reality today. Not the textbook version, but the actual day-to-day. You're in exam room 3.
Right, the trenches.
Exactly. You have a patient maybe, I don't know, 45 or 50 years old, and their BMI is sitting at 32.
Very common.
They don't have a formal diagnosis of knee osteoarthritis yet. Or maybe they just have those very early intermittent warning shots.
Yeah, like a little stiffness after a long drive.
Right, or a twinge on the stairs. And the standard clinical reflex in that moment is just automatic. We look at the chart, we look at the patient, and we say, you need to lose some weight.
Yeah, it's the eat less, move more mantra. It's almost a throwaway line at the end of the visit at this point.
It really is. And the assumption underlying that advice is basically intuitive physics. We assume that because excess weight mechanically loads the joint, taking off any amount of that weight, even 5 pounds, has to mechanically offload it.
It feels like a linear dial.
Yes, exactly. Turn the weight down a little, get a little benefit. Turn it down a lot, get a lot of benefit.
It's completely intuitive. It's logical. And according to the clinical evidence we're digging into for this deep dive, it is effectively wrong.
Which is a huge provocation. We're looking at a body of data that suggests you and I have been giving advice that sounds clinically sound but is physiologically useless.
Right.
So the clinical question we need to answer today is surprisingly specific. In an overweight adult without knee OA, does weight loss actually reduce the risk of developing symptoms? And more importantly, is there a magic number?
Well, the short answer is yes, there is a number. But it's not the number most of your patients, or frankly, most doctors are aiming for.
Because the data is telling us the benefit curve isn't a straight line.
No, not at all. It's a step function. It is a threshold.
So let's just put the thesis right on the table before we unpack the biological mechanisms. The consensus in the literature points to the fact that we need to stop thinking about weight loss as a gradient and start thinking about it as a gate.
A gate, yes. That's a great way to put it.
And the key to that gate seems to be 10%.
That is the critical figure, 10%. The evidence clearly indicates that without hitting a 10% reduction in total body weight, you as a clinician may not be seeing the results you expect regarding prevention or symptom management.
The magic isn't in the attempt, it's in the magnitude.
Precisely. It's the magnitude that dictates the biological response.
Which, honestly, is a terrifying thought for anyone working in primary care or sports medicine or orthopedics, because getting a patient to lose 10% of their body mass is incredibly difficult.
It's a massive hurdle.
But let's look at the why. Why is 10% the threshold? Why doesn't 5% do the job? I mean, think about it. 5% of a 200-pound person is 10 pounds.
Right.
That's practically a bowling ball off the knees. Why doesn't taking a bowling ball off the knees move the needle clinically?
To understand that, we have to look past the mechanics. You mentioned the physics earlier, the idea of loading and unloading.
Yeah, the wear and tear model.
Right. It's part of it, sure. But osteoarthritis isn't just a wear and tear situation. It's a metabolic disease.
That's a shift in thinking right there.
It is. Adipose tissue fat isn't just dead weight storage sitting on the body. It's biologically active tissue.
It's essentially an endocrine organ.
Exactly. It releases pro-inflammatory cytokines. Adipokines, IL-6, TNF-alpha. These things circulate systemically through the bloodstream, and they literally attack cartilage.
So when you have a patient with high visceral fat, they aren't just heavy, they're essentially in a state of chronic, low-grade systemic inflammation.
Yes. So the knee isn't just being crushed mechanically, it's being chemically attacked.
Okay, that makes so much sense, because the research suggests that a modest weight loss, say, in that 2 to 5% range, might reduce the mechanical load slightly, but it doesn't seem to be enough to dampen that systemic inflammatory fire.
Exactly. You haven't changed the metabolic environment enough to rescue the joint. You took the bowling ball off, but the chemistry is still eating the cartilage.
Wow. This completely explains the less is not more problem that gets highlighted so often in the clinical data.
We see it all the time in practice.
All the time. A patient makes a really modest effort, loses maybe 6 or 7 pounds. They come back for a follow-up and they say, my knees still hurt just as much.
Oh, it's our internal monologue there.
We think, well, weight loss doesn't work for them. Or worse, we think they must be lying about the weight loss.
Right. But the reality is likely that they just underdosed the treatment.
Underdosed. I love that framing.
It's like taking a quarter of an antibiotic dose and wondering why the infection hasn't cleared up. You simply haven't reached the therapeutic threshold.
The findings here are stark. Benefits for knee pain, for function, for quality of life, they all hinge on crossing that 10% line. Below that, the results are basically statistically noisy and clinically underwhelming.
It's just noise below 10%.
Okay, so let's talk about what happens when they actually do cross the line. Let's say you get that 200-pound patient to lose 20, maybe 22 pounds. They hit 11%.
Okay.
What does the outcome data actually look like? Are we talking about a subtle shift in their day-to-day, or is it a major transformation?
Oh, it is significant. Once you cross that 10% threshold, the data shows strong improvements in knee pain and function scores.
Like W-Angst scores?
Yes, robust changes in OBNX scores and functional mobility tests. You see moderate gains in overall quality of life. And perhaps most importantly for the long game, you see a moderate reduction in the risk of severe OA progression.
Meaning the actual structural deterioration of the joint slows down.
The evidence strongly suggests a protective effect against progression. Your confidence level as a clinician in this strategy goes from basically hopeful guessing to moderate or high confidence.
You're no longer just giving lifestyle advice at the door. You're applying a targeted therapeutic intervention with a known efficacy profile.
That distinction between guessing and treating is huge. It fundamentally changes the conversation you have in the clinic. Instead of lose what you can, the target becomes fixed.
But I want to pivot to who we are treating here, because the patient profile in your waiting room varies wildly.
It definitely does.
You have the person who is already wincing when they stand up from the chair, early symptomatic OA. And then you have the person who is just carrying extra weight but feels completely fine. Does the 10% rule apply equally to both of those groups?
This is where we have to be very precise with our language to avoid over-promising to our patients. We need to stratify.
Okay, let's start with early symptomatic OA.
These are the patients already feeling it. For them, the benefit is the clearest. The causality is incredibly tight. You hit 10%, you get symptom improvement. It is a reliable, proven intervention for pain.
So for the symptomatic patient, it's a slam dunk.
Yes.
But what about the asymptomatic patient, the 45-year-old who is obese but has zero knee pain right now? We want to prevent them from becoming the 55-year-old with bone-on-bone knees.
This is the holy grail of medicine, right? Prevention.
It is the holy grail, and honestly, the evidence there is much harder to pin down.
Why is that? Well, for the asymptomatic population, while we can certainly counsel them on potential benefits, we have to manage expectations regarding the prevention of incident symptomatic OA.
Meaning new onset disease.
Right. We are less confident that losing 10% of their body weight will purely prevent the onset of the disease, compared to how highly confident we are that it will manage existing symptoms.
That is such a critical nuance. You can't look an asymptomatic patient in the eye and promise, if you lose this weight, you will never get arthritis.
Correct. You absolutely cannot say that. You can say it reduces risk factors. You can say it improves overall metabolic health, which we know is linked to cartilage health. But the direct evidence for preventing OA from ever starting is tricky.
Because the longitudinal studies required to prove that are incredibly long and complex.
Very long.
Yeah.
And there are so many confounding variables over a 10 or 20-year period.
Which brings up the issue of surrogate outcomes. I see this used a lot in orthopedic discussions, and it drives me a bit crazy.
Oh, the total knee replacement stats.
Exactly. People will point to stats on total knee replacements, TKRs. They'll say, look, weight loss reduces the rate of knee replacements in a population, therefore it prevents OA from happening.
Yeah, and that is a logical leap we have to be extremely careful with. Yes, hitting that weight loss threshold reduces the rate of total knee replacements. But a TKR is a clinical decision. It is not a biological marker.
It's a sociological event as much as a medical one.
That's a perfect way to phrase it. It is influenced by surgical risk. Maybe the surgeon didn't want to operate on a high BMI patient because of the infection risk or anesthesia complications.
Right.
It's influenced by recovery time, patient eligibility, insurance criteria. Just because fewer people get the surgery doesn't prove we prevented the disease pathology itself.
It might just mean we managed the symptoms well enough to delay the knife.
Or that the patient was simply ineligible for the knife because of their weight in the first place.
Right. So we shouldn't conflate avoiding surgery with curing or preventing the disease. They are two totally different endpoints.
Exactly. So we have the target, 10%. We have the population, everyone benefits. But symptomatic patients see the most immediate return on investment.
Now let's talk about clinical decision-making. The decision moves. This is the practical application for you in the clinic tomorrow morning. How does this data change your default posture?
The default posture for overweight or obese adults, whether they have no OA or early symptoms, should be to recommend interventions specifically targeting greater than 10% weight loss. That is your baseline.
So if you aren't aiming for 10%, you aren't aiming for the clinical threshold.
Right. If you're aiming for 5, you're planning to fail.
Which means the polite, hey, try to cut back on carbs, or maybe take a walk after dinner, advice is totally insufficient. We are talking about structured interventions here.
We are talking about robust medical weight management, dietitians, structured exercise programs, cognitive behavioral therapy, and, yes, potentially pharmacotherapy if it's indicated.
The GLP-1s are changing the landscape completely.
We are seeing a revolution in medical weight management right now with GLP-1s and other agents. If the goal is 10%, you need a program that can actually deliver 10%. Handing a patient a glossy brochure on your way out the door isn't going to cut it.
And there's always a huge but in weight management, what if they can't? We all know patients who have been trying to lose weight for decades. The biology fights back, the metabolism slows down.
It's incredibly frustrating for them.
If we set a hard 10% goal and they stall out at 4%, what do? Do you just keep hammering on the weight loss?
Absolutely not.
Yeah.
That is what we call the pivot. And this is where the actual art of medicine comes into play. If a patient is unlikely or unable to hit that 10% threshold, maybe they've stalled, maybe they're just burnt out.
Yeah.
You don't just keep pushing a failed strategy.
You immediately add or shift focus to adjunct therapies.
Right. This connects directly back to that underdosing idea. If the weight loss dose is too low to work, you need to add a second drug, so to speak.
A different modality entirely.
Exactly. You bring in physical therapy to strengthen the quadriceps and offload the joint biomechanically.
Yeah.
You look at pharmacological pain management. You look at psychosocial support. You don't just stare at the patient across the room and tell them to try harder.
Because if they are stuck at 4% weight loss, they are in that no man's land where they aren't getting the anti-inflammatory metabolic benefit.
So you have to treat the symptoms via a completely different route.
I want to highlight the safety aspect here too, because in our enthusiasm for this 10% number as clinicians, we could accidentally do a lot of harm. We have to talk about contraindications.
This is massive. The prescription for 10% weight loss isn't universal. If a patient has severe comorbidities where rapid weight loss is dangerous cardiac issues, specific types of frailty, the calculus changes completely.
And significantly, if there is a history of eating disorders.
Oh, that is a massive red flag.
If I have a patient with a history of anorexia or bulimia who is currently overweight and complaining of knee pain, I am walking into a minefield if I lead the visit with, you need to lose 10% of your body weight.
Correct. In that scenario, aggressive weight loss interventions should be avoided or significantly modified. The risk of triggering a relapse into disordered eating far outweighs the potential benefit to the knee cartilage.
In those cases, the priority shifts entirely to safe symptom management, unloading bracing, PT, pharmacological management.
We cannot sacrifice the patient's mental or systemic health for the sake of a joint.
It's about treating the whole patient, not just the knee in isolation. And this leads right into the idea of monitoring. This isn't a set it and forget it prescription. You don't just say, lose 20 pounds, see you next year.
That is one of the biggest errors we make in primary care regarding OA. Delaying care because we are waiting for the weight loss to kick in.
Right.
If a patient is trying to lose weight and they've lost maybe 8%, they're getting so close. But the joint pain is actually getting worse. You need to reassess immediately.
Because the mechanism driving the pain might not be what you thought it was.
Right. The pathology might be much more advanced than early OA. Or, and this is crucial, they are losing muscle mass instead of fat mass.
Sarcopenic obesity.
Yes. That is a disaster for the knee.
Because they're essentially starving themselves to hit the arbitrary number on the scale.
It is. If you starve the patient to hit the 10% mark and they cannibalize their quadriceps in the process, you've unloaded the joint, yes, but you have also removed the primary shock absorbers.
The dynamic stabilizers.
Exactly. The quads act as the primary dynamic stabilizers of the knee joint. If you wither the quads to save the cartilage, you end up with a wobbly, unstable knee that might hurt just as much, just for entirely different biomechanical reasons.
So the 10% must be quality weight loss, fat mass, not lean mass, which implies we need to be strongly encouraging resistance training alongside any caloric deficit.
100%. Which brings us back to the need for a comprehensive, structured plan, not just a casual suggestion.
Let's spend a few minutes on the pitfalls. We've touched on a few naturally, but I want to explicitly flag what not to do. The biggest one seems to be what you called the linear fallacy.
It is easily the most pervasive myth in our field. We simply cannot assume any amount of weight loss provides equal incremental benefit. It is threshold dependent.
Right.
If you tell a patient every single pound counts, you are trying to be encouraging, which is kind. Doctors are generally nice people who want to motivate,
Yeah.
but you might be misleading them regarding the actual clinical outcome.
It's a really fine line between motivation and medical accuracy. We want to encourage them to start the journey, but we need them to understand that the relief, the actual clinical payoff, comes at the finish line at the 10%, not at the starting block.
Right. It actually helps to frame it for them like a financial savings goal.
How so?
Saving $10 doesn't let you buy the car. You need the full amount. Encouraging the $10 savings is good, but you have to be honest with them about the price of the car. If they stop saving halfway, they don't get half a car, they get nothing.
That's a brutal but necessary analogy. Another pitfall is the uncritical application of data. We touched on this earlier. Do not apply evidence from symptomatic OA populations uncritically to asymptomatic populations.
Don't oversell the guarantee of prevention. You lose all your credibility when you make promises the biology can't keep.
Right. If you tell an asymptomatic patient, lose weight and you'll be safe forever, and then they develop OA anyway due to genetics or a previous meniscus tear, you have broken trust.
Absolutely. And finally, the solo approach. I feel like this is where primary care often gets stuck because of time constraints. The 15-minute visit, lose weight, see you in 6 months.
It's a recipe for failure. Weight loss cannot be an island. It must be integrated.
If you aren't addressing the psychosocial barriers, why are they overeating? Is it stress, their environment, lack of access to quality food? And if you aren't using PT to strengthen the musculature around the joint while the weight slowly comes off, you are setting that patient up to fail.
And frankly, you are delaying care. That is the one that really scares me. The patient who is told to lose weight for 2 years while their joint basically grinds itself into dust, all because the provider wouldn't escalate therapy until the BMI dropped below a certain number.
I would argue that's negligent. If the weight loss isn't working, or if it simply isn't happening, you treat the patient sitting in front of you. You don't treat the patient they might be 20 pounds from now.
You have to manage the pain right now.
Exactly. We have plenty of other modalities. You have to use them.
So let's bring this all together. We have covered the biology, the metabolic thresholds, the pitfalls. If you had to write a golden rule on the prescription pad for our listeners, what is it?
The rule is clear. In overweight or obese adults, with or without early symptoms, prioritize interventions, aiming for at least a 10% reduction in body weight. That is the threshold for efficacy. That is the line where the biology actually changes from pro-inflammatory to neutral or anti-inflammatory.
But that rule has a pretty big asterisk.
It does. The asterisk is integration. This target must be paired with adjunct therapies, and it must be modified immediately if contraindications arise or if the patient's response is insufficient. The 10% is the primary goal, but it isn't the only tool in your box.
It effectively raises the bar for what we consider a successful intervention. We are moving away from the polite, try to lose some weight, to a much more rigorous, data-driven, we need to hit 10% to save this knee.
And I think that leads to the bigger question, one we all need to sit with after listening to this. Are we, as a medical community, inadvertently failing our patients by setting achievable but clinically insignificant weight loss goals?
Are we being nice by asking for 5 pounds because we don't want to hurt their feelings or discourage them, even though we know the biology demands 20?
That's exactly it. Are we prioritizing the comfort of the conversation in the exam room over the efficacy of the treatment?
That is a tough question. We are scared to ask for the 10% because we are afraid they won't do it, but by asking for less, we might be ensuring the treatment fails anyway.
It's a very tough spot to be in. But if we genuinely want to change outcomes, we have to be willing to provide the robust support needed to hit the threshold that actually matters. If we aren't willing to build the scaffold to help them climb that wall, we really shouldn't be surprised when they stay on the ground.
A 10% solution for a 100% problem. It demands a shift in clinical resources, a shift in mindset, and a shift in how you talk to your patients in exam room 3. Keep that in mind for your next clinical rotation.
Until next time.